Hello everyone, welcome back to the channel. Today we're going to be doing an exciting video on vascular surgery. So this is some of the content that we'll be covering today. We'll also have series of SBAs dotted throughout, so feel free to have a go, try as many as you can. This is a really high yield topic in exams. So to begin, we're going to be covering peripheral arterial disease, which is essentially an atherosclerosis of the arteries, which is a buildup of plaque leading to the narrowing of the arteries, which restricts blood flow, is caused by risk factors such as smoking, and it presents as a intermittent claudication or a leg cramping that can be worse upon walking and improves or is absent at rest. And usually the patient can walk a very predictable distance before the leg cramping begins again. In terms of investigations, we can do an ankle brachial pressure index. So below you can see how to calculate it, and in terms of interpretation, the main ones you want to remember is an ankle brachial pressure index of less than 0.9 suggests PAD, and less than 0.5 suggests severe PAD, and if it's over 1.3 it suggests stiff calcified vessels, which is most commonly caused by diabetes mellitus. Always check for the pulses, and in terms of imaging, first line is duplex ultrasound, second line is MRA. Here are some of the other differentials, and in terms of management, we want to prevent and reduce the risk from risk factors, so smoking cessation, because it's the biggest risk factor for PAD. We can give medications such as clopidogrel and statins to reduce the levels of cholesterol in the blood, which would improve the atherosclerosis. And if it comes to surgical intervention, we decide on the approach dependent on the level of stenosis within the artery and where within the artery it's happening. So if we have short segment stenosis, essentially there hasn't been stenosis it's only over a short amount of the artery of less than 10 centimeters, or if it's in the aortic iliac vessel, then we want to do an endovascular revascularization surgery. So this includes angioplasty or stenting. And if it's a long segment stenosis of over 10 centimeters, or is a multifocal lesion, is particularly affecting the common femoral artery, then we want to do an open revascularization, such as an artery bypass surgery, because it's a much worse kind of PAD. Other subtypes of PAD include acute limb ischemia and critical limb ischemia. So when I think of acute limb ischemia, you're thinking about the 6 Ps: pale, pulseless, painful, paralyzed, paresthetic, and peripherally cold. And acute limb ischemia is essentially a sudden decrease in the limb perfusion, which causes these 6 Ps. And it's typically caused by thrombosis or embolism. So risk factors of clots can be atrial fibrillation. And the first line and gold standard investigation is the handheld arterial Doppler ultrasound scan, and that'll help us to diagnose acute limb ischemia. And in terms of management, we want to give medications such as heparin. We're essentially trying to reduce the risk of blood clots, to reduce the risk of thrombosis and embolism. So, medications such as heparin will be greatly helpful. Surgery such as embolectomy to remove the clots, angioplasty combined with thrombolysis to break down the clots, bypass surgery. If a clot is blocking an artery, we can bypass it, and amputation is usually the go-to for critical limb ischemia, which is a more severe form where there is irreversible limb ischemia, and it's usually described in exam questions as a mottled, non-blanching appearance with hard, woody muscles. So when you see these buzzwords, think of critical limb ischemia, and it requires, unfortunately, urgent amputation because it's irreversible. And as always, we want to be reducing any cardiovascular risk factors, so smoking cessation, giving antiplatelets, statins, anticoagulation to reduce the risk of clots from AF, and encourage the patient to exercise and rehabilitate them. So have a go at this SBA. We'll have a go through it soon. So the correct answer is C. This patient clearly has PAD, so they have a cramping sensation, which is worse upon movement but improves or is absent with rest. And the particular subtype is acute limb ischemia because they have the 6Ps. They're periphery cold, they're parasthetic, their limbs are paralyzed, and they also have quite a lot of risk factors for acute limb ischemia, such as the atrial fibrillation. And if you remember back, the first line investigation is, and the gold standard is usually handheld Doppler ultrasound scan for acute limb ischemia. Duplex ultrasound can be given for PAD. However, this question is more denoting to the particular subtype of PAD called acute limb ischemia. So a more accurate and specific investigation for this would be the handheld Doppler ultrasound scan for the acute limb ischemia. And in terms of this question, again, they have PAD. They have the intermittent claudication condition that's worse upon walking, absent upon rest, the risk factors of smoking. He's also already being on some of the conservative management, such as the medications and the exercise program. However, it's still not helping, so this patient definitely needs surgery. And if you remember back to my teaching, we either need to give them endovascular revascularization surgery or open revascularization surgery. Endovascularly, if it's a short artery stenosis of less than 10 centimeters, or if it's in the aortic iliac vessel, then we go for a endovascular revascularization surgery, and that includes angioplasty plus or minus stenting. And if it was more of a long segment stenosis of over 10 centimeters, or if it was in the common femoral artery, then we would want to go for the open revascularization, such as an open bypass surgery. But here it's a short segment in the aortic iliac, so we want to do endovascular revascularization surgery, which is angioplasty or stenting. So in terms of this question, they have an ankle brachial pressure index of over 1.3. That means they have stiff and calcified arteries. The most common cause is usually diabetes mellitus. If it was less than 0.9, you would suspect PAD. If it was less than 0.5, severe PAD, and the in-between, so 1 to 1.2 is normal. Abdominal aortic aneurysms, triple A's, are expansive pulsatile mass that's caused by dilations of the walls of the abdominal aorta. So it's when the abdominal walls of the abdominal aorta become dilated by over 50% of its diameter, and that increases its risk of rupture. And some of the risk factors include being over the age of 65. So all men over the age of 65 are in the UK are offered a single ultrasound once they're 65 for triple A's. Other risk factors include smoking, hypertension, and other rare ones include Marfan syndrome, syphilis, Ehlers-Danlos type 1. Most abdominal aortic aneurysms are asymptomatic, but they can become symptomatic, especially if they've ruptured. So you'll typically present with abdominal pain, lower back pain, syncope, hypertensive, a rapidly expansive pulsatile mass, and tummy pain. Other risk factors for ruptured AAA include tachycardia, dizziness, sweaty, clammy, pallor, dyspnea. And the gold standard investigation is a single ultrasound scan that's offered to all men over the age of 65. And just learn the screening guidelines. So if it's less than 3 centimeters, usually it's nothing to worry about. Just want to reassure the patient. 3 to 4.4, we're starting to get is a little bit worried. So you want to refer them for an ultrasound every 12 months. 4.4 to 5.4, a little bit more worried there. Definitely, we want to refer them for ultrasound every 3 months. And if it's over 5.5 or centimeters in diameter, there's a huge risk of rupture. If the diameters increase by over 1 centimeter within a year, increased risk of rupture. If they're symptomatic, for example, they've got lower back pain, tachycardia, syncope, hypertension, abdominal pain, they're fainting, they're dizzy, they're clammy. All of these three things we want to urgently refer to vascular surgery within 2 weeks for a probable intervention, usually endovascular AVAR, or if needed, open endovascular revascularization. And some of the risk factors include rupture, thrombus, embolism, and fistulae. So according to the guidelines, it's increased by over 1 centimeter within a year. So we're worried and we want to urgently refer them within 2 weeks for EVAR. We always do endoscopic EVAR before open because it's just safer. You don't want the risk of infection as high with open. Now, varicose veins is dilated, tortuous, superficial veins, primarily found in the lower limb due to incompetent valves leading to the retrograde pooling of blood from the backside blood. So you can see in the images, some of the risk factors include, the main ones you want to remember is age, so the risk factor increases with age, female sex, standing for long periods of time, so occupational history is really important here. If they have a job or they're standing up quite a lot, it's going to increase the risk factor of varicose veins. Being on the combined oral contraceptive pill and progesterone levels during pregnancy in females and obesity are all linked with the risk of varicose veins. And like I said, they're usually described as dilated, tortuous, superficial, maybe edema, cramping, pain. First line, bedside investigations, ankle brachial pressure index. That seems to be our best friend in vascular surgery. And in terms of imaging, there's a series of imaging that we can do. The gold standard is usually a Doppler ultrasound. But if the patient has any signs of chronic venous insufficiency, for example, they're erythematous, you've got pigmentation, discoloration, dryness, with suspecting chronic venous insufficiency, edema as well, and we want to opt for the duplex. I just remember insufficiency, duplex, and then venography and MR venography. All of these are great imaging for varicose veins. And here are some of the differentials. And in terms of management, we want to manage conservatively by encouraging them to sit down more often, weight loss, elevate the legs. This can all help. We can give them compression stockings, which essentially helps us kind of squish the veins and improves the blood flow. However, always note the contraindication to compression stockings is if a patient has an ankle brachial pressure index of less than 0.8. We're thinking they've got limb ischemia, PAD, and that's a contraindication for compression stocking. And in terms of surgical, the first line is usually endovascular venous ablation or sclerotherapy. This is the first line regardless if they've got signs of chronic venous insufficiency. So if they've got edema, erythematous, discoloration, skin changes, the first line, no matter what, is going to be surgery. And the first line surgery is always endovascular venous ablation. So remember that. But otherwise, you would go for the conservative option, which is weight loss or elevating the legs, lifestyle changes, and compression stockings. And here are some of the complications. So the correct answer is C. She's got varicose veins, especially the fact that she's got all the risk factors. She stands up quite a lot with her jobs. Elevating the legs helps. She's got the dilated tortuous veins. But at this point, we know it's chronic venous insufficiency because she's got the dry erythematous purple discoloration. And with chronic venous insufficiency, we want to go for duplex ultrasound, and we want to treat them immediately with surgery, which is usually endovascular ablation, basically venous ablation, and duplex ultrasound is preferred when there's chronic venous insufficiency. Leg ulcers. So on the left we have arterial ulcers, and on the right we have venous ulcers. Arterial ulcers are most commonly associated with peripheral arterial disease, and they are caused by diminished blood flow to the distal tissues. And some of the ways that you can tell is that it will be described as having a punched out appearance, so deep and well circumscribed. It might be painful, they won't bleed or ooze. And in terms of venous ulcers, they may be described as inverted champagne bottle appearance, so tapering of the legs above the ankle. They typically affect the gaiter area, which is the medial malleolus regions, whereas the arterial ulcers affect more of the soles and the heels of the foot. Venous ulcers are usually caused more by chronic venous insufficiency, whereas arterial ulcers are caused by PAD. Venous ulcers can show up as lipodermatosclerosis, hemosiderin deposits, atrophy blanche, and arterial ulcers should have a punched out, deep and well circumscribed and painful appearance. Some other types of ulcers to keep a note of and bear in mind include margolin ulcers, which is a rare cutaneous squamous cell carcinoma of the skin, which develops at the site of a previous burn, scar, or ulcer, and neuropathic ulcers, which are typically occur in patients with peripheral neuropathy, and they involve a decrease or a lack of sensation in the feet, and the location is usually at a pressure point such as the sole or the heel, so they're kind of similar to lower leg to arterial ulcers, but typically they're painless, whereas with arterial ulcers it will be painful. And peripheral neuropathy is also associated more with diabetes, whereas arterial ulcers are associated with peripheral arterial disease. So I hope that was a good overview of vascular surgery. Thank you so much for watching. If you have any questions, please feel free to comment in the section below, and I hope it was really helpful. Thank you so much.